Good morning, everyone. Thank you for joining us on the second edition of the Ionis Rare Disease webinar series. I'm Sanjay Banat. I'm Senior VP, Chief Medical Officer, and the franchise head for the metabolic franchise at Ionis. And it is indeed a pleasure today to be able to discuss with you acromegaly, which is a rare condition that is caused by having excess of growth hormone in the body, and over time can lead to several problems, including enlarged hands, feet, and facial features. I am so thrilled today to really have a full lineup with me. First, we have one of the global leaders with us in the diagnosis and treatment of acromegaly, Dr. Shlomo Melman, who's Executive Vice President of Academic Affairs. He's Dean of the Medical Faculty and Professor of Medicine at the Cedars-Sinai Medical Center here in California. Shlomo?
Good morning to you, Dr. Banal, and to all of you else who are watching who are not on the West Coast. Good afternoon and good evening.
Thank you. Next, we have Jorge Fascinetti. Jorge is Chairman and CEO of the Pituitary World News. It's truly a one-of-a-kind information and news established source. It was established in 2014, and Jorge's journey actually compelled him to create a network to connect thought leaders to patients, which is absolutely critical, and thereby creating access to critical expertise for the patient real time. Jorge?
Hello, Dr. Beno. Thank you very much for including me in this. It's really great to be here. And hello to everybody listening as well and watching us.
Thank you. Last but not the least, it is such a pleasure to have with us Risa. Risa is a patient who once was an endurance athlete. She was an outdoors woman and adventure seeker. She was diagnosed with acromegaly in 2018, and she has combined her passion for cycling and spreading awareness in the hope that she will get information out to those who need it most. And it is really a pleasure to have Risa join us today as well. Risa?
Hi, Dr. Banal. Thank you so much for having me on. I'm so grateful to be here, to share my story.
Thank you. Thanks, all of you, for being here today. Just a few housekeeping items before we begin. We will have a live Q&A session at the end of our discussion. So if you have a question you'd like to ask, please submit it through the question and answer feature, and the team will select a few of these questions that we will attempt to answer today. When you submit your question, please be sure to note if your question is for Risa, for Jorge, Shlomo, or myself, or for two of us, whatever you'd like us to address specifically. Also, the webinar is being recorded, and the video replay will be available on the Ionis website at ionispharma.com. With that, just wanted to give you a very quick overview. The reason we have these distinguished guests invited today really is to share their perspectives on what the disease is, what the current treatments are, and then actually have Risa help us understand why and what are some of the symptoms and some of the treatments that they don't address. And so I think we're going to start off with that at the start of the seminar. Acromegaly is a rare disease. There's actually less than around 20,000 patients each year in the US. And so our goal is at Ionis is to inform patients about rare diseases such as acromegaly and also educate them about the potential treatments out there. Collaborating with patients, caregivers, patient advocacy groups, as well as healthcare providers is an initiative that is very critical to Ionis. We've taken on this initiative with tremendous enthusiasm over the past few years because we know that our patients depend on us, and we are there to deliver innovative treatments and therapies for our patients. So without further ado, what I'd really like to do is to ask Shlomo, Dr. Melmed, to give us a brief introduction on what acromegaly is, what are the causes, and what might be some of the treatments that are available to patients today. Shlomo?
Well, thank you, Sanjay, for that overview. Well, yes, you are absolutely correct. Acromegaly is a rare disease, but unfortunately, this is an inexorable chronic illness which persists unless it's treated. Acromegaly is caused usually in about 95% of patients by a pituitary tumor, a benign pituitary tumor. It's never malignant, it's benign. It hypersecretes growth hormone. And the hypersecreted growth hormone impacts the liver to manufacture production of another growth factor termed IGF-1. And both IGF-1 and growth hormone together act at the periphery to induce multiple changes on body systems. So acromegaly really is a disease of two parts. It's a component of an expanding benign pituitary mass at the base of the brain, and it's a reflection of the impact of high levels of growth hormone and IGF-1 on all the peripheral systems. And the most important peripheral impact, which is deleterious to the patient's health, is development of joint changes, bony overgrowth, arthritis, sleep apnea with soft tissue swelling, diabetes, high blood pressure, and heart failure. So the challenge for the endocrinologist is to control the tumor growth or to ablate the tumor, and most importantly, to control the peripheral effects of the high levels of growth hormone and IGF-1, either by blocking their secretion by the tumor or by blocking their action and thereby preventing all the deleterious side effects that I mentioned. So that is the disease. In terms of treating the disease, we have several mechanisms and tools at hand today which we can employ to control the disorder. There are three broad categories for management: surgery, which is commonly used; radiation, which is very rarely used, especially in the USA. We rarely use radiation to treat these patients unless surgery and other treatments have failed. And finally, we have a basket of medical therapies, which comprise three classes. And these three classes are available for use by the endocrinologist in treating these patients. They are somatostatin receptor ligands, which can be injected or can be taken orally. Their second class are dopamine agonists, and the one that we use is the long-acting cabergoline. We're not going to talk much about that because in our hands, cabergoline is not really an effective care. And thirdly, a peripheral growth hormone receptor antagonist, and the paradigmatic molecule is pegvisomant, which acts at the periphery to block growth hormone action on generating IGF-1 and block the deleterious effects of the high hormones at the periphery. And using an integrated, comprehensive approach, a team approach by a neurosurgeon, by an endocrinologist, together with an expert imaging physician, we are able to offer our patients a personalized approach using these tools to control their disease. But I want to emphasize that the control is long-term. It requires years, decades, and often lifelong therapy for these patients with the goal of maximal control of the disorder.
Thank you. Thank you, Dr. Melman. That's very informative. So, Risa, could you give us a perspective on how you went about in terms of diagnosis for the disease? What are some of the challenges, like Dr. Melman said, for patients to get to an endocrinologist before they start getting this comprehensive treatment? And then why and how much do you feel the treatment actually benefited you, especially in terms of symptoms that may go beyond some of the biochemical control that Dr. Melman was talking about?
Sure. Well, there's so many layers to the story of someone who's living with acromegaly or pituitary disorders. I'd say at about 8 years before diagnosis, I knew something was wrong in my body. I was an endurance athlete, raced in Ironmans and long distance cycling tours and CrossFit. And so I was very in tune with my body, but I knew something was wrong. But the symptoms were kind of just vague. Fatigue, maybe my knees hurt a little bit, or, heavy sweating, things like that. So it wasn't until about 5 years pre-diagnosis that I really started noticing changes in my body that I just couldn't understand. So I started going to doctors, my primary care physician, and, we were exploring through blood work, and my blood work was fine. And so there was really no questioning. I was told numerous times that, oh, you're an athlete, you're healthy, your blood work's fine. And I was like, no, you don't understand. I know something's wrong. So I started doing my own research, and I kept thinking it was my thyroid, and my thyroid levels would come back normal. And it wasn't until about the fourth doctor where I demanded a MRI, brain MRI, because I was having really bad headaches. And I was about getting about 2 hours of sleep each night. The headaches were so severe. And she denied my MRI 3 times. So I finally demanded, I was like, I'm not asking anymore, I'm demanding an MRI. And 1 week later, I got one sentence from her in an email saying, you have an enlarged pituitary, you need to go see an endocrinologist. And I had no idea what an endocrinologist was or what that meant. Yeah. And it was then when I saw the endocrinologist that I found out I had a pituitary tumor.
Yeah, we've actually had the same experience when we've done pair as well patient research and asked patients very similar experiences like you've outlined, Risa, is delay in diagnosis, seeing it on an average 3 to 5 physicians before they really get to someone like Dr. Melmath who can diagnose and treat it properly. I'll come back to the treatment part in just a little bit, but Jorge, could you give us a quick overview on how you and the organization that you founded can actually help patients in terms of earlier diagnosis, overcome some of these obstacles in terms of getting diagnosed with the disease, and then subsequently put them in touch with the right physicians and specialists?
Sure. Thank you. Yeah, thanks for the opportunity. Well, we started Pituitary World News in 2014, and just like Risa, my story was, very similar. But I was around 28 years undiagnosed, and that was based on some photographs that we looked at. When I walked into my neuroendocrinologist office, his comment was, "You're a doorway diagnosis." I look at you, I know exactly what you have, and which I thought it was very interesting. And we started Pituitary News asking precisely the question of why. Why does it take so long to recognize or to diagnose, and what would the advantages be if we could shave off, several years of that wait? So the idea was to generate really more conversation about acromegaly, about other pituitary diseases. But for me, acromegaly was very important because that's what I was diagnosed with. So I think the way we help is really by enhancing the conversation, by providing a forum for people to come to discuss it, to talk about it, physicians, uh, patients, families, all healthcare workers that come to the website to read the content. We've been, I think, much more successful than we thought we were going to be, because when Dr. Blevins and I started it, we said, the question they asked me is, "How do you do this?" Okay, well, it was in my wheelhouse. I worked in the communications business for many, many years, and I'm sort of a frustrated publisher, so I've always wanted to do this. So I said, listen, we just get started and let's see what happens, and let's see what we get and what we learn. And we started fine tuning things. Now we have over 500 pieces of content. Um, we have almost 110 podcasts that keep getting hits. People start listening to these things. So
Yeah.
we're trying to figure out how to truly quantify what we've done, and that's a job in and of itself. So,
Yeah.
but it's interesting. We get 10,000 at least 10,000 hits a month, or anywhere between 8,000 and 10,000, which I think it's quite remarkable for a publication
Yeah.
like
That's
this.
great. That's
So
amazing. I think
yeah,
it's a lot of good that you are doing for the patient, and I think,
Absolutely.
yeah, that's excellent. Truly, hooray.
yeah. Thank you for saying that.
Sanjay, what Jorge and Risa are describing is really epitomized in the literature. The median time for diagnosis in the documented studies ranges from 5 to 10 years of delayed diagnosis. So the stories that we're hearing today are emblematic of worldwide experience. And the problem is that the symptoms are so common: high blood pressure, mild diabetes, joint pain, headache are very common symptoms. And acromegaly is a very rare disease. So the primary care physician is challenged when a patient presents with new onset headache or new joint pain or hypertension. The primary care physician is challenged to even think about a rare disorder because these symptoms are so common. That is the challenge which we're hearing. These true human stories by Risa and Jorge.
Yeah,
I,
that's true. That's absolutely true.
if I could add, I think that Dr. Merriman is we totally correct. That's what we hear in the stories, as you were saying, are very, very similar. And for us, the dynamic is when we think about it simply, we say, well, look, if we can increase the awareness of people in general that these uh, diseases exist, and we can somehow put it on the radar sooner on the primary care physicians or healthcare professional, then maybe they suspect it sooner rather than later.
Right.
And probably 2 years makes a heck of a difference. From, to use a baseball term, a bunt here becomes a home run.
Yes.
That's true. That's true. I think I agree completely, Ray, with what you
Yeah.
said.
Yeah.
So, Risa, then, once you got diagnosed, we talked about the delay in diagnosis and how there's tremendous need to cut down that time frame. Why? We also know that it's barely probably 60% at most patient satisfaction in terms of the overall treatment that includes symptom control. Dr. Melmed laid out for us a lot of the symptomatology that the patient experiences that goes beyond normalization of growth hormone or IGF-1 levels as well. And I think it would be very helpful if you could outline for us what your treatment journey has been and how have you experienced some of these symptoms, including some of the breakthrough symptoms that patients often talk about. Um, why don't you tell us a little bit about your treatment journey?
Sure. So I have to say, treatment for me has been frustrating, but with that said, I remain hopeful. I'm trying a third medication. The first two aren't working, but let me back up a little bit. I had surgery in 2019. They were unable to remove the entire tumor.
Mhm.
And so I was told basically my only option was radiation treatment. So I did proceed with radiation treatment. And as we wait to see if that works, I'm trying a series of different medications that so far my IGF-1 is not managed. So I'm still battling the acromegaly symptoms. And I think this is where like pituitary world news comes in, is I just simply didn't have the information. I didn't even know what acromegaly was. I'd never heard of it, and I didn't know what treatment options were out there. So for as a patient, I feel like I didn't have enough information, or nor was I given enough information. So also, I went from being a super crazy neurotic athlete, extremely detailed. I had my own event planning business, and so I was very sharp and organized. And all of a sudden, post surgery, it's like I woke up in a new body. I could barely get out of bed, and my memory and cognition was off, and I was making mistakes and very fuzzy and feeling like I'm walking around underwater. And not to mention the joint pain and just all kinds of crazy stuff that come along with, post, just not to mention acromegaly, but post surgery, and then the side effects that come with different medications. So I feel like I'm a newbie in this, and I'm still learning. 3 years later, 2 years, 3 years later. So I think feel like
you're right. I think that's what the value of Hooray and the network, especially that education, really, really comes in. And I think what you've talked about in terms of what we hear from patients often is it's kind of this brain fog, as well as the sweating piece, as well as the joint pains. And even though there are times where the biochemical control may appear that you've kind of almost near normalized IGF-1 levels and corrected that, the symptomatic control is just isn't there for the patients.
Yeah.
And they keep getting these breakthrough symptoms. Shlomo, what do you think?
Absolutely, you're absolutely correct. So, I think that Risa's story really is emblematic of what happens in the treatment community. So, firstly, in terms of the primary care physician and the internist, this is a rare disorder. They may never in their entire lives ever encounter a patient with acromegaly. And then once the patient is sent to an endocrinologist, in endocrinology, we deal with hormones and hormonal disorders, and the most common hormonal disorder is diabetes. So all of our endocrinologists see thousands and thousands of patients with diabetes before they will see a single patient with acromegaly. They may see a patient with acromegaly once in 2 or 3 or 4 or 5 years. And so what Risa is experiencing in terms of decision points in treatment, it emphasizes the need to try and have your disease managed by a team of neuroendocrinologists who are focused on and experienced in dealing with acromegaly or with other pituitary disorders in a center which is able to integrate all the disciplines focused on the patient with the pituitary disease. And the question that you've just raised, Risa and Sanjay, is even if the endocrinologist controls the IGF-1 levels and the growth hormone levels, and even if the surgeon has performed a maximal resection of the mass, and the patient is on good, controlled treatment with few side effects, they come to the doctor, and the doctor looks at the numbers and says, well, you're controlled. Your IGF-1 and your growth hormone are normal. And the patient says, no, doctor, I'm not controlled because I don't feel normal.
Right.
I still have joint pains. I still sweat. I still get headaches, especially towards the end of the month if they're on monthly injections. Yeah. And so there is this discordance. And there have been several very elegant studies published in the last 2 years showing quite definitively, objectively, using objective quality metrics, patient-reported quality metrics, that there is this discordance between how the patient feels and what their biochemical abnormality is reflected in a normal result. And
Yeah.
that's the challenge for endocrinologists today, to try and maintain drug levels, sustain drug levels throughout the month, to prevent breakthrough symptoms, and
Yeah.
to address all the subjective quality of life deleterious impacts which patients are reporting to us despite biochemical control. And so what RISA is telling us is really a very, very significant challenge for treating endocrinologists.
Yep. I think that is so helpful to hear you say that, because those are exactly things that we have observed, and when we have spoken to patients as well, is very similar to what Risa outlined, that as there is, even with these once a month somatostatin analogs, as they start wearing off, you can see that the breakthrough symptoms start appearing. So, in addition to getting the IGF-1 levels reduced and under control, it's a sustained reduction of IGF-1 levels so that those breakthrough symptoms don't appear, like Shlomo is saying, which is just absolutely so critical. And the other thing that perhaps Dr. Melmond, you could put some light on, and Lisa, I know what in terms of medical therapies, what you've experienced is that we've heard that a lot of the treatments, it's very laborious. For many of them, you have to go to either the physician's office, or for some of the daily treatments, the patients feel that there is tremendous need for something that they could take that's more simpler, that would also therefore then assist in compliance of the drug. What do you think, Dr. Melman, your experience being with the patients?
Well, until very recently, all the somatostatin receptor ligands had to be given by a painful injection, usually at the clinic, at the hospital, or at the doctor's office. So the patient has to miss work. The patient has to undergo a painful, very, very deep intramuscular injection, or for another product, a less deep subcutaneous injection, and it is uncomfortable. And as you correctly point out, and towards the end of that 28-day cycle, symptoms break through. The availability of an oral somatostatin is very recent, and we don't yet know what the impact will be on symptom breakthrough. But hopefully it will be an additive to help those patients. In terms of the growth hormone receptor blockers, the pegvisomant, the single product available, that requires a daily injection every single day to block growth hormone action. And patients develop very fatty overgrowth in the area of the injection. And there are some side effects associated in about 5% of patients with elevated liver enzymes. And so the peripheral growth hormone receptor antagonist pegvisomant is very effective in blocking IGF-1 production, but unfortunately requires a daily injection.
Thank you. So, Jorge, what are some of the more common questions or pieces of information that through your network you get from patients, either in terms of treatment control, and we talked a little bit about diagnosis. Can you shed a little bit of light on where you feel giving out some of the key pieces of information have been tremendously helpful?
Sure. Well, we really get a gamut of comments and questions through the website and through the social media channels. But no doubt, the breakthrough issues are top of mind with people. What Dr. Melmed just mentioned about the discrepancy between the doctor saying, look, your IGF-1 level is in control. Yeah, but I don't really feel that good. And that we hear constantly. So those are the the key issues. Beyond that, we hear a lot about emotional and mental health issues and support. We hear a lot about the relationship between the physician and the doctor and how to improve that. What we hear a lot about, I'm not getting the right treatment. My doctor isn't listening to me. And obviously, like Dr. Melvin and you mentioned, not everybody can land at a great pituitary center, which there are some. We have quite a few in this country. So I think that we hear about how do we get that type of treatment to more areas, to more people. So we've had. But consistently, I will tell you that when we publish something that has to do with emotional or mental health support, the response almost tripled to our. So we get 3 times the amount of readership that we do. And then the other thing is, access to resources. So the way we try to do it is to write something and then provide the links to the centers of excellence to people getting the right information. We are, this is a little bit separate from the subject, but we're very concerned about the amount of misinformation and disinformation that there is on the web. So we try to focus people on the right information.
Yeah.
I just wanted to make one quick point, because I know we're nearing the end of our time. Although these are very important patient quality subjective symptoms which we have to address, controlling the IGF-1 is important, because there is strong data that if you control your IGF-1, you remove the adverse effect on mortality.
Yeah.
And so controlled IGF-1 is still vital to preserve the long-term health of the patient.
Yeah.
So I want to make sure that we understand the balance of the discrepancy between IGF-1 control and the patient's symptoms.
Yeah.
I think there's a little. I totally agree with Dr. because I think that there's not misinformation, but confusion about a comorbidity or a related symptom. Where for example, in my case, I have 3 one knee replacement, 2 hip replacements because of. But I have to deal with that with arthritis as a separate issue. My acromegaly is totally controlled.
Right.
Yeah, I think it's a.
Yeah,
it's a very important point, I think, and thank you, Shama, for bringing it out. That we're not talking about just symptom control, but that is something that we need to get a handle on, in addition to getting the IGF-1 under control, which is the basic pathology. Exactly. I think we'll probably try and move on to our question and answer session, I think, towards the end as well. So once again, to our viewers, please submit your questions to the Q&A link, and please add in who you would like the question to be answered, so we can probably wait and see if there's some questions coming up. So I actually start seeing some. The first question is for Risa, Jorge, and Dr. Melmet. So what are some of the drawbacks of the current treatment and some of the unmet needs as we move forward with treatment? I think we talked about it, so maybe Dr. Melmet, maybe you could start. Again, reiterate to patients, and then I think the other piece to it is for Dr. Melmet is in some of the studies you mentioned where patients still do have symptoms, even if they are biochemically controlled. Can some of those links of studies be made available?
I'll answer the second question first about the studies. Yeah, that are discussed. Yes, there are 2 very, very significant studies published in the last 2 years. One is from Dr. Geer, Geer, in New York, and the other is by Dr. Christian Strasburger in Berlin, in Germany. And those 2 studies are reflective exactly of what we were just spoken about in terms of breakthrough symptoms and patient feelings and patient quality of life despite biochemical control. So I would urge you to look at those two studies, Geer and the other one is Strasburger. In terms of the current treatments, of the drawbacks and the advantages, well, when we look at treatments, we look at advantages, disadvantages, safety, and efficacy. Is a treatment working? And to fulfill all those four requirements of understanding by the physician and the patient will result in an answer to the question, what are the drawbacks? So you weigh up with the patient the advantages, the disadvantages. We've heard one disadvantage from Risa about radiation, for example. The disadvantage of radiation, even though it's very effective, is it may take many, many years to work. And in some studies, up to 10 or 12 or even 15 years before radiation works. So that's a disadvantage. And in the meantime, patients like Risa require medical treatment to control their disorder. In terms of surgery, the big disadvantage is that despite the best surgical expertise, the small amount of tissue that's left behind by the surgeon because it's inaccessible to the surgeon continues to hypersecrete growth hormone, and that's a disadvantage of surgery. In terms of the medications, each of the medications has side effects. There are the side effects for somatostatin analogs, which are diarrhea, abdominal discomfort, a feeling of nausea, slow pulse. Those are some of the and development of gallstones, which are usually asymptomatic.
Mhm.
In terms of the growth hormone receptor antagonist, we've discussed the side effects. Most importantly, the side effects are those of rarely occurring liver damage. So each treatment is effective, but each treatment is not totally safe. And we have to value judge the balance, the benefit versus the risk to the patient for each of those treatments that we've mentioned, which requires an experienced and informed discussion. And what Jorge said is so important. The discussion has to be informed by fact rather than a lot of misinformation that is on the web.
Great. So, so one of the things that, go ahead, Risa, you wanted to say something.
I just wanted to, reiterate that for me as a patient, it's having all the information. That's one of the drawbacks is, all the information isn't there. So.
I know, and it's very interesting that it's come up, 2-3 times today, but it's something that is so critical, which is why organizations like one Jorge has are so important for the patient. It seems to be obvious, but that if you don't have the right information in front of you, you're going to not make not just the most informed, but the wrong decisions probably. So that's very interesting. So one of the things, Risa, if in hindsight there was maybe one single thing that you could think of that would have led you to get a more timelier diagnosis as you think through your journey and as you think through what happened, what might that be?
Oh gosh, I've thought about this a lot actually. I am now on with my 8th doctor, who actually is a specialist in acromegaly and pituitary diseases, and I'm paying out of pocket because this doctor isn't in my network, but it's so worth it to me to be connected to someone who understands and will help me explore all the options and give me all the information.
Sure. So another question that's just come through is for Risa, so maybe you can continue, and then Dr. Melman. And the question is, how do you manage the breakthrough symptoms? So once they do come up and you do keep experiencing some of those symptoms, are there options on how to manage those symptoms? Technically, once your tumor is gone, and your IGF-1 levels are normal or near normal, how do you manage that? Maybe Risa and then Dr. Melman.
Okay, sure. Well, for me at that point, it becomes a mental game. And so what I do, I could either spend my time on the couch being frustrated, or I can get on my bike, which I'm passionate about. And it's amazing when I do something I love and I immerse myself in that. It changes my whole mentality. So I get off my bike, and for that time, I forgot about the knee pain. I forgot about, the headaches and the fatigue, and mentally, I am in a better place. So that's how I personally have come to manage, those breakthrough symptoms, and which seems to now be every day.
Okay.
So, but I have hopes for moving on to the
Yeah.
next medication.
Yeah. Dr. Melma, do you have anything to add to that?
Yes, for managing breakthrough symptoms for patients who are on monthly somatostatin injections, we have a couple of approaches. The first is we use an off-label, not approved. I want to emphasize that, not approved, an off-label approach by adding once a week a pegvisomant injection, the growth hormone receptor antagonist, low dose, once a week, added in combination to the monthly somatostatin injection. So that approach works for many patients, and we've used that successfully, but I want to emphasize it's not approved and it's not on the label. The second approach is new. We don't yet know the impact of taking an oral somatostatin every day, thereby preventing the nadir of drug levels which may occur after the long-term injection. And we're now trying to use the oral octreotide to prevent breakthrough symptoms. We don't yet know, and the studies haven't yet been done, and it's not approved. So we can't yet give a definitive answer. And then the final suggestion is that if the IGF-1 is also not controlled, and you have symptom breakthrough, the patient may require a second surgery. And sometimes a second surgery in the hands of a more experienced surgeon is effective. So those are some of the approaches we would take to patients who have a persistent breakthrough symptoms and signs of acromegaly, despite the fact that they're on a somatostatin injection.
Yeah, I think it makes a lot of clinical logic is that you add low dose of a second treatment.
But it's not approved. I want to emphasize, it's not approved. We're in the public domain now, and I'm not going to promulgate anything that's not approved.
Yes.
It's an approved drug for a non-approved indication and given in a different fashion than the label suggests.
Yeah. But I think for new therapies, which are trying to get better patient control as we move forward, is that clinical concept is very important. That if you have ongoing breakthrough symptoms despite near maximal doses of the therapy, then using an alternative approach that may be complementary to what's out there could be a clinical series of hypotheses that could be tested.
You're absolutely right, especially if it provides a sustained high level, effective level of drug.
Yeah. So here's another question, interesting question. It says, it's for Dr. Melman. If I have had surgery to remove the tumor and I feel better, should I or why should I have treatment?
Well, that's a great question. If you've had surgery and you feel better and the MRI shows no residual tumor and the IGF-1 is normal, you need no further treatment. And statistically, you have a very good chance of long-term control. I don't like using the word cure, but just long-term control. And there is about a 10% chance that over the next 5 years or 8 years, the tumor may recur. But 90%, if you're totally resected, your tumor is totally resected, your IGF-1 is normal, and you're feeling good, you're in a good place, and you don't need further treatment. You just need to be monitored over the long term, once in 6 months, once a year, by an experienced endocrinologist.
Thank you. Thank you. So
that, by the way, is our goal. That question is our goal. Tumor is gone, IGF-1 is controlled, you feel good, and we'll just follow you and shake hands and have a nice discussion every year as we follow your health.
Right. So a
Absolutely.
follow-up to, or another question in those lines for Dr. Melmoth was, um, could or would a successful radiation therapy eliminate the symptoms? I think you clearly mentioned one of the drawbacks, which is often it takes such a long time for this to work. And actually, recently, maybe you could add on after Dr. Melmoth, because you've actually had
Oh, no,
experience.
Risa, you can
Why
tell
don't
us
you
your
start?
experience.
Yeah,
Risa,
please
you
go
tell
ahead.
us your experience.
It's perfect.
Yes. Well, I mean, of course, I just had radiation treatment in 2019, and it could take, as Dr. Melman said, 10, even 15 years. My IGF-1 is not under control, but it presents its own set of symptoms and side effects. And so I'm dealing with much of that right now, but is it that? Is it not that? I don't know for sure. No one will tell me, oh, it's definitely that. So I have to draw my own conclusions based on how I feel in my body.
Yeah. Well, Rita is experiencing what is common in this country, in that certain centers would have expertise and good experience with radiation and offer radiation to their patients very effectively. In our pituitary center, we rarely use radiation, and the most important reason is that what we've mentioned earlier is that radiation takes a long time to work. And then radiation also damages the surrounding normal pituitary gland. So patients like Risa may require, in the long term, replacement of other pituitary hormones, like taking a thyroid pill every day and taking estrogens. So I would urge Risa, patients like Risa who have undergone radiation, that they have their pituitary tested. It's not a serious problem. It's easily manageable, but you should have your pituitary tested every year or two, going through the rest of your life, because the replacement of those hormones, which could have been damaged by the radiation, is very easy and very safe. And there are oral pills. And then finally, we have to mention that our radiation colleagues are getting very, very much better in their approach to radiation. So Risa undergoing radiation in the last couple of years is in a completely different category of those people who underwent radiation 5, 10, 20, even 30 years ago. And so not to be alarmed by the side effects which you see in literature, because the side effects for radiation that are reported today are a reflection of what happened decades ago.
Yeah.
Yeah.
Radiation is far more focused, so we don't see the deleterious side effects. And I don't want to scare anybody, but the older literature really was a little bit alarming to patients and to physicians. So that is put aside now, because our radiation therapy colleagues are so much more focused and so much effective, especially during the last 5 years. So it's a value judgment. If you prepare to wait 5, 10 years, if you prepare to have your pituitary tested, there's a good chance that over the next decade, your disease will be controlled.
Yeah, I think it's a very key point that often patients don't consider, which is pituitary doesn't control and doesn't result in just growth hormone problems, but it is like a master center in the body controlling so many other organs and hormones. So it's just so critical to make sure you get followed up. So the next question for maybe Jorge, you could start, and then Risa, is what advice would you give to a patient who's just starting their journey living with acromegaly?
Oh,
Now in hindsight, yeah.
wow, that's a big one. Well, no, that's a great question. I would tell you, based on my experience and what I hear, is that for me, it was just realizing that there was a new normal, that we're going to having to deal with this for the rest of my life, and that I was going to just get up and get on with it. So the sooner you can do that, the better it is. And the other thing I would tell you is that what helped a lot for me was trying to learn as much as I could about the disease and how it affects me. I remember my friend and partner and neuroendocrinologist, Dr. Blevins, said to me once, you can have 150 people with acromegaly in a room and have 150 different disease states. And that really stuck with me, because even though you hear what everybody else goes, just learning exactly how you deal with it, it's critical. So I would urge you to do that.
Okay. Risa?
Right. Yes, I would agree with Jorge. Is get as much information as you can, uh, and also what's helped me is to find the things I love. I like I said, I had a choice to could sit on the couch and be depressed or get up and live. And so I've really taken this opportunity to embrace life um, and and also how can I do my part? And so a little plug here, I'm riding my bike from down the West Coast
Oh
from
yeah.
Washington to Mexico,
Yeah.
leaving in September to spread awareness, because if I didn't have the information, I know there's a lot of other people out there that don't either. So, and I'm doing it through something I really love. So, and it's super filling.
Okay. Thank you.
Yeah.
Well, I think we probably can wrap up. Thank you so much to all three of you. I think it's been an incredible conversation. I would say a start to a conversation around this.
Yeah.
I think the key, of course, being that patients are really, really encouraged to really try and get all the key information and make sure it's not in misinformation, and to use sites like the Pituitary World Network, News Network for that. I hope to the viewers you enjoyed some of the discussion today, and would urge you to continue in terms of the patients to make sure you get to an earlier diagnosis if you're having any of the symptoms that are unexplained, as well as what the best treatment options for you are. So thank you all of you once again. Thank you to the
Thank
viewers,
you.
and we will await our next webinar series.
Thank you,
you.
everybody.
Thank you.
Bye-bye.
Thank you.
Bye,
And
everyone.
good luck to.
Thank you.
Thank you.
Bye-bye.